Good afternoon. I call to order this remote meeting of the House Commerce Committee and will ask Mr. Brown to take the roll.
Chair Stevenson.
Here.
Vice Chair Katiza-Wattoon.
Here.
Representative O'Driscoll.
Present.
Representative Barr.
Present.
Representative Carlson. Representative Davney.
Present.
Representative Elkins.
Present.
Representative Haley.
Present.
Representative Cagle.
Present.
Representative Lee.
Present.
Representative Lilly. Representative Lislegard.
Present.
Representative Lucero.
Yes, sir.
Representative Olson.
Present.
Representative Farr.
Present.
Representative Rasmussen.
Present.
Representative Richardson. Representative Tice.
Present.
And I will call the names again. Representative Carlson.
Present.
Representative Lilly.
Present, sorry.
You're good. And Representative Richardson.
Present.
Thank you all.
A quorum is present. Our first item of business is approval of our minutes from our last meeting yesterday. Representative Katiza-Wattoon, have you had a chance to review the minutes from February 2nd?
I have. I would move approval of those minutes, Mr. Chair.
All right. Discussion to Representative Katiza-Wattoon's motion. Hearing none, all in favor say aye. Aye.
Aye.
Aye.
Aye.
Opposed? The motion carries and the minutes for February 2nd, 2021 are approved. Today, we have three bills on our agenda, all three of which relate to healthcare pricing and transparency, and all three are authored by Representative Elkins. Representative Elkins has some summary remarks at the outset that hopefully will put these three bills into context. So I'm going to recognize him for about 5 minutes to just briefly kind of outline the three bills, and then we'll move on to our first bill. Representative Elkins.
Thank you, Mr. Chair. I'm going to share my screen here. Second, okay, and yes, need to go back to the front. There we go. So overview on this is that the theme is, healthcare pricing transparency. So the key question I pose is that, is there anything else that we buy that can cost us hundreds or even thousands of dollars, or we would feel like it's normal and acceptable to place our order with the understanding that we'll only learn what the price is going to be after we've taken delivery, while accepting an obligation to pay the price, whatever it is after the fact. So we wouldn't, and so why would we do this during healthcare? So this collection of bills, House File 57, 58, and 59, all attack different parts of that problem. And if you looked at any one of them individually, you might say, probably, some testifiers today will say, is that the scope of this particular bill is so inconsequential, it provides so little useful information that what's the point? Well, the point overall is that if you take the information that's required to be provided under these three bills and combine them together and combine them with other sources of public information like Medicare, Medicaid reimbursement rates, Medicare spending data, you can come up with a pretty good comprehensive view of what healthcare is costing. So 57 is related to hospitals and other shoppable medical services. It builds on a foundation of a CMS hospital pricing rule that started in 2018, was updated and greatly improved for effect on January 1st of this year. And it reveals list prices and actual price ranges, including the charge master list price, the self-pay price if the provider has one, and the median and minimum maximum reimbursement rates. So all of these data elements are required by the CMS pricing rule and have been since the beginning of the year. All 57 does is say, guys, let's put this into a consistent format so that that the data can be consolidated, and instead of just looking at one healthcare provider organization, we can produce reports across provider organizations for comparison purposes. House File 58 relates to drugs. It builds on Kelly Morrison's House File 1246 last year, which was passed into law. It will reveal list prices, two of them, the wholesale acquisition cost and the average wholesale price, which we'll discuss in more detail when we get to that bill. And we'll also, talk about the significance of why those two. And then this bill also composes two articles. The first is the price reporting. The second one is relates to formulary stabilization. 59 is very simple. We're actually going to hear that one first. And it just relates to improvements to the state's existing all-payer claims database, which has been of somewhat limited use because much of the data in it is stale by the time it's entered, and because it's not historically been complete in scope with data missing. If you go back far enough for Medicaid plans, a lot of employer plans, ERISA plans have been missing. And so this bill will just greatly improve the quality of the data that's reported to the all-payer claims database, and then open it up for reporting on prices by service and provider. And throughout here there'll be some slides that just have reference information that you can look at afterwards. The links will all be active. But I think, Mr. Chair, I'll give it back to you, and we'll introduce House File 59 as the first one.
All right, and as you allude to, Representative Elkins, the first bill that we'll take up will be House File 59. Representative Elkins, would you like to move your bill?
I would like to move House File 59, and its next stop after here will be the Committee on Judiciary and Civil Law.
So Representative Elkins moves House File 59 be recommended to be referred to the Committee on Judiciary, Finance, and Civil Law. And with that, Representative Elkins, the floor is yours to describe the bill.
Okay, so I will go back to the presentation. Okay, so 59 is probably the simplest and most straightforward of the three. So the all-payer claims database, for anyone who's unfamiliar with it, is a repository of healthcare claims records which are submitted to the Department of Health by Minnesota Health Plans. All-payer claims databases are promoted under federal law, and many states have them. Their purpose is to support medical research and reporting. And from a privacy perspective, it's important to understand that all of the data in the all-payer claims database is de-identified. All personally identifiable information has been stripped out. The database itself is very well secured. The usage of the all-payer claims database has been limited because under current state law, only semi-annually submissions are required, so that by the time the data gets there, in many cases, it's stale. Some of the plan administrators withhold data from employer finance ERISA plans, in many cases without actually asking the employer if they would like their data contributed to the database. And in most cases, it's in the employer's interest that it is. So the scope of the data has been somewhat incomplete. And under current statute, the all-payer claims data cannot be used for price reporting because of earlier negative experiences with using the stale, incomplete data for this purpose. So it's before my time, but apparently early in the days of the creation of the all-payer claims database, there was a program called provider peer group reporting, and it did not go well because the data quality in the database at the time was just not very good. So the objectives require monthly submissions so that's timely, leverage language that's in the just recently passed Federal No Surprises Act, which encourages the submission of ERISA plan data to improve the scope, and then allow the improved data to be used for reporting by procedure and provider. So I should note that reporting by provider and health plan is actually prohibited by state law to preserve the confidentiality of negotiated rates. And then this would, could be used to, supplement the price data required by House 57 and 58. So if you combine the list prices required by 57 and 58 with the actual price data out of the all-payer claims database, you get a pretty good comprehensive representation of what prices are being asked and actually charged in the marketplace. And just a note on the side is that in the No Surprises Act, Congress appropriated a grant of $2.5 million for state to fund these kinds of programs that would improve the quality and usage of all-payer claims database and open up their uses to for reporting. So a number of stakeholders were involved in the development and comments on 59. And there are no amendments because, well, they did not receive any. So I think at this point, we're okay to open this up for testimony and questions, Mr. Chair.
All right, thank you, Representative Elkins. And we do have a couple people who have signed up to testify. I did note, Representative Elkins, on your PowerPoint, you mentioned the Department of Health. I don't know if the Department of Health is on here. They weren't on my list, but if they wanted to testify, you should probably go there. So is there anyone from the Department of Health?
Yeah, Mr. Chair, Stefan Gildemeister from the Department of Health, who is my liaison at the Department of Health on these projects, is here to answer questions and may wish to say a few words as well.
Mr. Gildemeister, did you want to comment on the bill or just be available for questions?
Mr. Chair, the letter would be enough.
I think Stefan is freezing out.
Yeah, I couldn't, he said something, but I couldn't quite make it out. So I will move on to the other testifiers, but Mr. Gildemeister, if you can hear this and you want to make comments, please just let me know by email or otherwise. The first testifier who signed up is Dr. Marilyn Pizzo. I'm sorry if I mispronounced that.
Pezzo, you're close.
Pezzo.
Yes.
Dr. Pezzo, the floor is yours.
Yes. Okay, thank you. Mr. Chair and members, my name is Dr. Marilyn Pezzo, and I'm a pediatrician practicing in St. Cloud, and I am the president of the Minnesota Medical Association. I testify in support of House File 59. The MMA supports the all-payer claims database. The APCD offers the unique ability to capture claims data across nearly all healthcare payers in the state and has allowed the health department to use the data to analyze variations in healthcare costs, quality, utilization, and illness burden based on geographical areas or populations. Access to data is and always has been the way to improve care and quality. Physicians appreciate the power of data to focus inquiry and expand knowledge. The health department reports released to date that are based on the APCD have helped to expand our understanding of chronic disease trends, pharmaceutical spending and use, price variations in medical treatments, and frequency of low-value services, as just a few examples. Many of the current restrictions on the use of and access to APCD data limit its potential and undermine our collective learning about healthcare delivery in Minnesota. The APCD has important limitations. The data are not timely enough to be used to support quality improvement efforts, nor is the data timely or granular enough to support purchasing decisions by employers, nor to allow comparative healthcare shopping by individuals. House File 59 does change to monthly the frequency by which payers must submit their data. This will help address some of the criticisms of the APCD, and the MMA supports these changes. The MMA also strongly supports Section 4, which directs the commissioner to develop recommendations to expand access to the APCD to other researchers. The bill also proposes changing the classification of the APCD data to allow the release of identifying data on hospitals, clinics, and individual providers. The MMA supports greater system transparency and believes that improvement can be accomplished through public reporting. This change, however, comes with risks, both to the confidence and trust in the APCD and to the reputation of individual physicians and other healthcare providers. The MMA would ask that the proposed language in lines 2.33 to 3.1 and 4.4 to 4.5 be stricken. We request that the issue of releasing identifiable data be incorporated instead into section 4, so that the recommendations on how and under what circumstances identifiable data should be appropriately released may be subject to more thoughtful consideration. Thank you, Mr. Chair and members. I am happy to answer questions.
Thank you, Dr. Paetzo, and we'll get through all the testimony, and then if you stay on the line in case members do have questions. The next testifier is Bentley Graves from the Minnesota Chamber. Mr. Graves.
Thank you, Mr. Chairman, and thank you to Representative Elkins for bringing this bill forward. My name is Bentley Graves. I'm with the Minnesota Chamber of Commerce. We represent 6,000 employer members across the state in all industries, all sizes of business, all corners of the state. We work on healthcare issues because healthcare costs are a major concern for our rank and file employers who provide this important coverage to their employees. Year in, year out, as we talk about healthcare costs and health insurance issues with our members and their employees, transparency often bubbles up to the top of the list. Transparency in prices and transparency for quality as well. Minnesota has had the all-payer claims database, as Representative Elkins said, for a number of years, but this legislation would carry the important work that's been done with it forward in a couple important ways. And I want to say that we are fortunate to be in Minnesota, where we have a number of transparency tools at our disposal that aren't available in other states, like with Minnesota Community Measurement and others. But the moves made in this bill would certainly improve the usefulness of the APCD as a tool in that toolbox as well. I note the comments made by the MMA, and I suspect that there are similar comments coming from the Hospital Association as well on some of the finer points of the granularity of the data changes made in the bill. But we certainly want to be involved in the conversation going forward to find a way to make some of these improvements, particularly again around as was mentioned before, Section 4, that really opens up the APCD as a tool for others to use in helping to find new ways to bring down costs and improve outcomes for employers. So I want to thank Representative Elkins and support this important legislation and look forward to continuing on in the conversation as the bill moves along. Thank you, Mr. Chair.
Thank you, Mr. Graves. We will now move to member discussion and questions. Just a note for members, in case you missed the motion from Representative Elkins was for referral to the Judiciary and Civil Law Committee, which of course has primary jurisdiction over questions related to handling data. So to the extent that your questions and comments relate to items that are more squarely under the jurisdiction of that committee, I'd ask that you kind of hold back. We do have 3 bills. We are going to get through all 3 bills today. So maybe we can save that discussion for the next committee. Representative Lucero.
Thank you, Mr. Chair. And I feel that those comments were directed squarely at me, so I appreciate the friendly reminder. But to Mr. Chair and to Representative Elkins, so I won't ask a question. I'll just express the concerns given what the chair had just said, and that is on line 3.22 and 3.33, where it is making clear that the identity of individual patients can't be given, but that the identity of payers is obviously the change that's being made. And when the additional existing languages is viewed, I see, for example, on line 1.13, there's clearly an attempt to de-identify, right, to protect the PII of individuals. Yeah. But when we look at rural Minnesota, where there is people that might be going to clinics, by identifying certain clinics and depending on the conditions or the ailments or whatever a patient might go to a particular clinic, even though the individual isn't named, by naming the clinic, and if it is a particular condition that they're being treated for that might be sufficiently less common, that might inadvertently the change that's being made here, being proposed, might inadvertently then allow for somebody to be identified. So I just want to put that on the table, that I do have a concern with the further and further we go with allowing information to be included, to be uploaded to the state, it poses such risks. So thank you, Mr. Chair.
Thank you, Representative Lucero. And my comments weren't directed at anyone in particular, but I very much appreciate you taking them into account. Representative Elkins is unmuted. I don't know if you wanted to respond.
No, Representative Lucero and I actually share a very strong interest in data privacy. And so I understand and appreciate his comments. I mean, the provisions in line 1.13 and 1.14 are existing provisions. They're basically there to comply with HIPAA requirements. In the database, the closest thing to identifying data there in terms of data elements is 3-digit zip codes, age, not date of birth, and gender, which are there because location, gender, and age are important variables in medical research. But I should also point out, in the new Federal No Surprises Act, there is actually a clause in there related to all payer claims databases nationally that makes it a crime to try and re-identify data in an all payer claims database. And Mr. Gildemeister, if we have, I would probably be able to speak to the fact that the all payer claims database is very secured, very well secured.
Well, we'll let the data conversation continue in the Judiciary Committee for now. Representative Haley.
Thank you, Chair Stevenson, and thank you, Representative Elkins. I share your concern about price transparency. It's very complex, and our constituents, often bring this up. The entire industry is very complex, so I appreciate the work you've put in. This is hard to get right. So I just have two concerns, and we don't need to drill into it today, but I just wanted to go on the record. One of my concerns just is about there's a $50,000 cost here for MDH to secure a vendor to make some recommendations. We haven't had a good track record in state government of IT projects. And so my concern is just the scope of that. Would we run into a significant additional cost? Would we end up with something that is really usable? So again, I would just like to kind of understand more. And on those same lines, I have a concern about, again, the importance of doing this right and the amount of work that is on MDH's plate right now in managing COVID, frankly. That is this the right time to undertake this significant effort? So again, appreciate all your efforts and the outcome that you're trying to achieve. Those are just two things that are on my question list today with your bill. Thanks, Representative Elkins. Thank you, Chair.
Representative Elkins.
Thank you, Mr. Chair. Yeah, with respect to the cost, the existing processes are already in place. The main change is from semi-annually to monthly reporting. Actually, most of the plans are already reporting monthly data. It's actually easier because the data volumes come in smaller chunks and can be processed more easily. And then there will be additional volume as well as, let's say, for example, more ERISA data is contributed to the plan. But other than additional volume, for this initiative, the amount of extra work will be modest, and the $50,000 should be adequate. And then I'll point out again that if we're in line to receive a $2.5 million federal grant explicitly to do this kind of work. Mr. Gildemeister has told me that he does not expect to have firm guidance from the U.S. Department of Labor about what exactly will be required in order to tap into that money, probably until the October timeframe. But that's out there available longer term as a data source, a revenue source to fund these types of efforts. And I'm not expecting that anybody either in the plans or in the Department of Health is going to be doing any work related to this for at least the next several months.
All right. I don't see any other members seeking to speak here. So Representative Elkins, would you like to make any closing comments?
No, I think the questions have been good. The support has been heartwarming, and so I would like to renew my motion that we refer this bill to the Committee on Judiciary and Civil Law.
Representative Elkins renews his motion to recommend that the bill be re-referred to the Committee on Judiciary, Finance, and Civil Law, and Mr. Brown will take the roll.
Chair Stevenson,
Aye.
Vice Chair Cotizo-Wattoon,
Aye.
Representative O'Driscoll.
No.
Thank you. Representative Barr,
Yes.
Representative Carlson,
Yes.
Representative Davney,
I probably better let you run.
Sounds good.
All
Let
right.
me know if you hear more. I'll talk to you later.
Well,
Representative O'Driscoll, if you could, yeah.
Representative Davney,
Aye.
thank you. Representative
Thank you.
Elkins,
Aye.
Representative Haley. Sorry, Representative Haley,
Oh, I'm sorry. No.
thank you. Representative Cagle,
Aye.
Representative Lee,
Aye.
Representative Lilly,
Aye.
Representative Lislagard,
Aye.
Representative Lucero,
No.
Representative Olson,
Aye.
Representative Farr,
No.
Representative Rasmussen,
No.
Representative Richardson,
Aye.
Representative Tice,
No.
With 12 ayes and 6 nays, the motion prevails, and House File 59 is recommended to be referred to the Committee on Judiciary, Finance, and Civil Law. Our next file on the agenda is House File 57. Representative Elkins, would you like to move your bill?
Thank you, Mr. Chair. Yes, I would like to move that, introduce the House File 57 and move that it be referred to the Committee on Health, Finance, and Policy.
All right, Representative Elkins has moved that House File 57 be referred to the Committee on Health, Finance, and Policy. Representative Elkins, the floor is yours to describe your bill.
Great, thank you. Back here again. Come on. There we go. Excuse me for 1 second here. No. 57, here we go. Okay. Yes. This one deals with an existing CMS federal rule that went into effect, as I said, originally in 2008, but with dramatic improvements in terms of the data that needs to be provided effective with January 1st of this year. So the new version of the federal rule, effective January 21, requires hospitals to post the following information on their website. So their charge master list prices, the cash prices for uninsured persons for each service, the median price that the hospital receives, and the minimum and maximum prices received by the hospital for each service, and the current reimbursement rates for each health plan for that service. And it requires that that information be provided in a machine readable format, such as Excel or comma-separated values, that can be imported into a spreadsheet or database. And that requirement is there because the anticipation by CMS is that the data will be imported into databases and used to create comparative price reporting among providers. So the problem that we're experiencing that this bill is intended to address is that the federal rule does not specify the format of reporting that data. And so in response to the 2018 rule and this year's rule, each of the hospitals that is creating these files is posting the data in their own unique formats, which thwarts the use of the data for price comparison purposes. And so I pulled a couple of these spreadsheets myself. The first one was Hennepin Healthcare's file. The second one was a file for Alina's Abbott Northwestern Hospital. And I pulled the data for a particular CT scan that I, as a cancer survivor, will be having on Friday. And so the information here is, you know, a little more than academic interest, but I just wanted to illustrate here that, you know, that you have two organizations providing essentially the same data, doing it in such a different format that it's very, very difficult to then take this data and import it into a database for comparison purposes. So if you, you just, so this is, so you can see in here that these are the same services. So the billing code 70490 is, you know, a CT scan of the soft tissue of the neck. And you can see that, you know, the same code is here in the same place. You know that it's comparable. But the format is just very difficult. But as to, you know, why someone would want to do this kind of a comparison, you can look at some of the comparisons that you can find on here and find that that for Hennepin Health, the gross list price for this procedure is actually broken into two pieces, but one of them is $1,000 there, where it's only $550 at Abbott Northwestern. Here, and I know that this will come up in the testimony, it can be hard to come up with apples and apples, but in the case of Hennepin Health also, this is broken into actually two charges. This line where the 351 is for the scan itself, 960, and this code means that it's you know, professional services. So this is a separate charge for the radiologist to actually read the data, whereas here it's bundled. So I will acknowledge that one of the things that will work out when we start using this data is how to appropriately recognize apples and apples and bundled versus unbundled services. But yeah, the point here is that this data is good data, it's useful data, but only if it can be pulled together and put into a reporting tool to make it user-friendlier for actual consumers to be able to go on and shop and compare prices among organizations. And it's just very, very difficult with the individual hospitals making such big differences in the way they're providing the data. And so what this bill will ask them to do is, you know, agree on using the same format for the machine readable files. And then additionally, it will require the hospitals to transmit these files, a copy of these files, to the Department of Health, so that the Department of Health can import the data into the database and create a user-friendly report with it. And focusing really on the creation of price comparisons for what we would consider, you know, shoppable services. These aren't going into the emergency room. It's things like getting a CT scan or an X-ray, or having a you know, hip replacement or a knee replacement, where you've got some time to make a decision and do some shopping. And then the bill also extends this requirement, you know, to other providers of these same shoppable services, you know, such as orthopedics and radiology, because if you're going to enable a shopper to shop for, you know, what's the best deal on a hip replacement, it's silly to only include the hospitals when a majority of hip replacements are probably done by specialty practices like Twin Cities Orthopedics, Summit Orthopedics, or TRIA, and being done in outpatient surgery centers rather than hospitals. So the bill also brings them under this umbrella, so that the data, you know, here combined with the data in the all-payer claims database will provide consumers with a good overall picture indication of what their procedure is going to cost, depending on where they have it done. And I think, oh, I should mention the other thing that the CMS rule requires is a display of shoppable services in a consumer-friendly format, but only for a sampling of procedures around. I think they have to. Each hospital has to do this for about 300 procedures, and also looking around for good exemplars. In this case, my own home hospital, Park Nicollet, part of the Park Nicollet chain, or Methodist, they're doing an exemplary job of this, and you can kind of see here an example of the presentation of price information on the Park Nicollet website, where you can see description of the procedure, the billing code, the average cost, the range of the costs, and these are elements that are required by the CMS reporting. And they have also added in the Medicare reimbursement rate, the Medicaid reimbursement rate, and the self-pay rate for the uninsured, which is one of the elements, again, that's required by the federal CMS rule. So on the whole, I mean, we're saying is that we're not asking, consulted with tons of people on this, but we're not asking the hospitals to provide any data that they are not already required to provide and post on their websites by the federal CMS rule. All we're asking is that they provide it in a consistent format so that it's easy to integrate into a database and provide a copy of it to the Department of Health in order to enable them to create a user-friendly price shopping tool. And Mr. Chair, I do have two authors' amendments for this bill.
I think now would be a good time to consider those. Did you want to move the A1 amendment?
Yes, the A1 amendment just changes in the original bill. There was permissive authority for the Department of Health to create this reporting. We're changing that to a shall. The Department of Health is comfortable with taking on the responsibility for developing this. And then the second change was requested by the hospitals, and it was a perfectly reasonable request. The original language in the bill, which is the A2 amendment, the A2 amendment basically said, the original language was that the language in the bill would become effective upon enactment. And as previously been stated, it's completely unreasonable to expect that either the hospitals or MDH would start working on this immediately. And so in the A2 amendment, the effective date is changed to January 1st, 2022, to give us all the opportunity to work on the finer details of the format of the layout and what kind of work is going to be involved over the interim. And I have volunteered my own time. I am otherwise retired and spent the last 10 years of my career doing this kind of work. So I've offered my services for free to help in this effort as well. So I suppose we have to do these one at a time. So I'll first move the A1 amendment.
All right, Representative Elkins moves the A1. I'm going to ask Representative Elkins if you could stop the screen share there so that we get a good visualization here. Any discussion to the A1 amendment, which is an author's amendment, getting the bill in the shape that he wishes the committee to consider the bill in? Seeing no discussion, all in favor say aye. Aye.
Aye.
Aye.
Opposed? And ayes prevail and the amendment is adopted. And Representative Elkins, did you want to move the A2?
I would like to move the A2 amendment, Mr. Chair.
All right, Representative Elkins moves the A2 amendment, which is another author's amendment, getting the bill in the shape the author would like the committee to consider it. Is there any discussion to the A2? Seeing no discussion, all in favor say aye. Aye.
Aye.
Aye.
Opposed? Motion prevails and amendment, the A2 amendment is adopted. We'll now move on to testimony on the bill. We did have one person sign up to testify on this bill. So Joe Schindler with the Minnesota Hospital Association. Mr. Schindler.
Mr. Chair and members, thank you very much and good afternoon. My name is Joe Schindler and I am the Vice President of Finance, Policy and Analytics at the Minnesota Hospital Association. I'm here today to address the hospital and health system's concerns with House File 57. For 11 months, our hospitals and health systems have served their patients and communities under extreme circumstances. At the same time, they have responded to multiple requests for data from the state in order to respond to the crisis. Minnesota hospitals' information technology and data resources have been stretched thin with the development of new electronic health records updates, daily data submissions to the state's MinTrack bed tracking system, daily data for the federal teletracking reporting system requiring over 70 data inputs, the state's vaccination tracking program called the Minnesota Immunization Information Connection, or otherwise known as the MIC, and these are to name a few. On behalf of our members, I request that you not impose another data requirement on top of thinly stretched resources during a pandemic. Now in January, as Representative Elkins did point out, CMS did establish a new rule requiring hospitals to show 5 charge levels in a machine readable format for all inpatient and outpatient procedures. This was effective January 1st of this year. The second part of the regulation is to provide price estimates for over 300 shoppable services, either as individual services such as diagnostic imaging procedure or for bundled services such as the delivery of a baby. This part of the regulation is the most useful for consumers and is already available for consumers seeking price information. The state does not need to set up a separate process to display the same information that is already available. Now, part of the intent of CMS was to encourage IT vendors to collect the machine readable files to create a marketplace of shoppable healthcare services. This massive amount of pricing information has just become available as of this January. So our suggestion is to give it some time for vendors and researchers to analyze the information before feeling compelled to spend state resources to collect and display data for the state. One additional comment I'd make to House File 57. MHA believes that health plans are in the best position to provide consumers with a good faith estimate of healthcare prices. They have the experience data from across the entire healthcare continuum, and health plans have the most real-time information about what a consumer would have to pay for any given provider. A more workable and consistent solution would be to require 10 to 15 of the largest commercial health plans to produce these files rather than forcing hundreds of providers to develop them. So I thank you for considering the concerns of our healthcare system community. I would note that we have had an opportunity to meet a couple of times with Representative Elkins to discuss our concerns with him. And we look forward to continuing these discussions as the bill is considered through its legislative process. Thank you.
Thank you, Mr. Schindler. I do see Representative Elkins is unmuted. I don't know if you wanted to respond to that. Representative Elkins.
Yeah, as I pointed out in my comments, the displays that I'm seeing related to the shoppable, the user-friendly shoppable services stuff, some of it's really pretty good, but it's limited to generally no more than 300 services. And in my own personal experiences, including looking at the Park Nicollet site that I pointed out as an exemplar, that's where I will be going to have my CAT scans on Friday, but neither of the CAT scans that I will be having Friday is on that list. And I found that generally the same thing. I love the Minnesota Community Measurement site as an example. Similar sort of presentation, but I have never been able to find information about a service that I was going to have performed at a facility where I was likely to have it performed available on that website because the data is limited in its scope. So this bill will make data available in a form that it can be turned into a consumer price shopping tool that is comprehensive. It's not just a sampling of representative services.
Thank you, Representative.
Yeah, and like I said, I'm very eager to continue working with the hospitals. I completely recognize the strain that they're under. When I spoke with Deepthi Panditi at Hennepin Healthcare about this last week, we were both in our offices at 7 p.m. So I know what kind of stress they're under right now. And like I said, there's no hurry to get this done right now. We can put this off until later in the year, and I'm happy to continue working with you guys on this stuff.
Thank you, Representative Elkins. And I think it is a good reminder to the committee that we did adopt an amendment moving the effective date to next year. Representative Haley.
Thank you, Mr. Chair, and thanks again, Representative Elkins, for the bill. A lot of my concerns were mentioned by Mr. Schindler already, but I'll make a few comments. Representative Elkins, I chaired a hospital board for 5 years, and so my concerns are centered around that. and the cost and the burden, especially for a smaller rural hospital. And my experience in that is that it would ultimately then raise costs. And that is our overarching concern, is how do we bring down healthcare costs for consumers? And I'm wondering if, as this develops, as there's more time that the CMS rule is in place, if there will be some best practices that will emerge around the country that we can learn from and emulate. And also just the rapid pace that apps and technology change, that we might learn how consumers will better access data. I found in chairing that hospital board that consumers want this data, but will they go get it? You are probably an exception because you're a technology person. So you clearly have spent a lot of time in this field. But I found that many of our customers would not navigate a site like this to find the data. They'd rather pick up the call to their health plan and have a person on the other end walk them through it. So again, maybe that changes over time as this rule is in place and apps are developed, and we find maybe private market sector things that help solve this problem versus a government trying to do it. So again, appreciate the problem and the effort, and just wanted to share some of those comments and why I will be voting no, but I appreciate the scope of what you're trying to accomplish. Thank you, Representative Elkins. Thank you, Chair Stevenson.
And I see Representative Elkins is unmuted again, so I'm taking he wants to respond. Representative Elkins?
Yeah, just a reminder, this bill does not require hospitals to produce any data that they are not already required to provide. In fact, most of them are already providing it. All it would require them to do is rearrange the order of the columns. And the purpose of that is to make the data more inviting to third parties, whether it's Department of Health or Minnesota Community Measurement or some private firm that might want to take this data and render it in a more consumer-friendly manner. In the form in which it's being published right now, no third party would want to take on the effort that would be involved in trying to take 128 separate hospital files from hospitals around Minnesota and have to figure out how to reconcile the differences in the layout. Thank you.
All right, Representative Katiza-Watun.
Thank you, Mr. Chair, and thank you, Mr. Elkins, Representative Elkins, for just reiterating that the data is simply being reorganized. Did I hear you say that the standard template is going to be provided and then the information just needs to get inputted as well, or how would that?
Representative Elkins.
Thank you, Mr. Chair, and Representative Katiza-Watun. By and large, the data is being provided on these spreadsheets. I showed 2 examples from local hospitals. All that has to be done is the columns have to be arranged, put in a consistent order. So, and you would appreciate this being an IT person yourself. It requires an extract, transformation, and loading job to take the data from the spreadsheet and upload it into the database. If all of the data is in the same format, you only have to write one ETL job to load all of 128 of the files instead of having to develop 128 ETL jobs, one for each different file.
Representative Katiza-Watun.
Thank you, Mr. Chair. That really seems like a no-brainer to me. If the order is being established by the state and then shared with those hospitals, just reorganizing the data seems like it would make a much bigger impact on the consumers to make it accessible. If they're providing the data already, but consumers aren't able to read it or understand it, then I don't really understand what the point of the current process is. So I appreciate you bringing this forward. Thank you.
Thank you.
Representative Dabney.
Thank you, Mr. Chair. And I just want to start by observing that I understood almost nothing of what Representative Elkins just said to Representative Katiza-Watun, but I'm glad that the 2 of them understood each other. But more transparency is a good thing, and I will be supporting this bill. However, Representative Haley made a very good point. We don't have a market in healthcare. And it's a bit of a fool's errand to think that I'm going to approach calling my healthcare provider and making the same decision-making process that I do when I buy a new coffee maker, or to decide which brand of yogurt has the coupon at the grocery store this week. And all of these attempts to bring market pressures to healthcare usually come to naught because it's not the same sort of decision-making. It's not the same system. And we probably need to look instead outside of a market-based approach if we want to get some of the costs out of healthcare. We know that Medicare has a much, much smaller administrative cost than the health plans do, that there's a lot of bloat and waste at the health plans. There's a lot of bloat and waste at the hospitals that we support through trying to take a market-based approach. I just wanted to make that comment that I'll be supporting it, but ultimately pretending that we have a market in healthcare, I think, is a fundamental error. Thank you, Mr. Chair. No offense, Representative Elkins.
Thank you, Mr. Chair. Yeah, first I would say that we've never provided a meaningful shopping experience, so we don't really know how consumers will behave, especially when we have more and more consumers who are on high deductible health plans where they're on the hook to spend the first $7,000 of their plan. I know that when I broke my elbow in 2017 on the heels of having cancer surgery, and being on a health plan that had an $8,000 deductible, I did a lot of shopping. But it's really hard. It's much harder than it needs to be. And the second point that I would make is that the data that we'll be producing as a result of these bills is also going to be very informative to us as policymakers trying to understand where the waste and abuse is. I mean, you'll see just even in that one example that I presented, the differences in the prices between those two hospitals was glaring. Why? Is there really, does Hennepin Healthcare really cost twice as much to provide that CAT scan as Abbott Northwestern does? So we're going to get some very important insights ourselves as a result of the provision of this data.
Thank you, Representative Elkins. Representative Rasmussen.
Thank you, Mr. Chair, and thank you, Representative Elkins, for your thoughtful work on this important issue. My question is for Mr. Schindler. Mr. Schindler, in the district I represent, we have a smaller independent hospital healthcare system. And I was wondering if you could talk about what kind of lift this is going to be for those smaller rural health systems hospitals, and any idea that you have on just the cost and effort that would be associated with standing this up. Thank you.
Mr. Schindler.
Mr. Chair, thank you, and Representative. Yeah, for sure. We've got over 140 hospitals across the state. Most of those are small rural hospitals. This is a major cost for them. They, generally speaking, they can't do this on their own. They have to have this farmed out through a consulting firm of some sort. So there is some cost involved. I don't know exactly what some of those costs may be, but it's probably upwards of $10,000 just to rearrange a file even. So it's, and I would say on top of that, rearranging a file really doesn't even get you to the comparability that you're looking for. But that being said, the small rural hospitals would have a sizable cost to this.
Representative Rasmussen, any follow-up?
No, thank you, Mr. Chair.
All right, I have a follow-up. Mr. Schindler, though, the requirement to produce the data is a federal law. It's not this state law that requires those small hospitals to produce this data. Is that correct?
Yeah, Mr. Chair, that is correct. It's a federal law, or it's actually a federal regulation. Yep. Yeah.
And I think the point here is just the manner in which it's produced, not the requirement to produce it. They're already on the hook to produce it. There's no further discussion. I do want to be mindful of the fact that we have one more bill. Well, I do see Representative Driscoll. You raise your hand, Representative Driscoll.
Thank you, Mr. Chair. Just to follow up on this, I thought we were good, but I want to just clarify. Mr. Schindler, the $10,000 that you were talking about would be to take that federally mandated data that's already being produced and rearrange it. That was your rough estimate, correct?
Correct.
Mr. Schindler?
Oh, sorry, Mr. Chair, that is correct.
So, Mr. Chair.
Representative Driscoll.
Then to Representative Rasmussen's point, it is a somewhat redundancy of services, which means that hospitals would be spending more on paperwork and bureaucracy than they would on patient health care. You don't really have to answer that question, Mr. Schindler, but that's what it appears to me.
All right, thank you, Representative O'Driscoll. I do want to move on to the next bill. There's no further discussion. Representative Elkins, if you have brief closing comments, I'll give you the opportunity, and then please renew your motion.
No, I think we've had a good discussion on this, so I will renew my motion that we refer House File 57 as amended to the Health, Finance, and Policy Committee.
All right, Representative Elkins moves to recommend that House File 57 as amended be referred to the Committee on Health, Finance, and Policy, and Mr. Brown will take the roll.
Chair Stevenson.
Aye.
Vice Chair Cotiza-Wattoon. Representative O'Driscoll.
No.
Representative Barr.
No.
Representative Carlson.
Yes.
Representative Davney.
Aye.
Representative Elkins.
Aye.
Representative Haley.
No.
Representative Cagle.
Aye.
Representative Lee.
Aye.
Representative Lilly.
Aye.
Representative Liz Lagarde.
Aye.
Representative Lucero.
No.
Representative Olson.
Aye.
Representative Farr.
No.
Representative Rasmussen.
No.
Representative Richardson.
Aye.
Representative Tice.
No.
And again, Representative Cotiza-Wattoon.
Mr. Chair, Simon, can you hear me? I can't hear anything, but I can see the boxes moving that people are responding.
Yeah, we just heard your voice.
Okay, I approve. I say aye.
Thank you.
Sorry about that.
No problem, Representative Cotiza-Wattoon. With 11 ayes and 7 nays, the motion prevails, and House File 57, as amended, is recommended to be referred to the Committee on Health, Finance, and Policy. The last bill on our agenda today is House File 58. Representative Elkins, would you like to move your bill?
Mr. Chair, I would like to move the approval of House File 58 and its referral to the Committee on Health, Finance, and Policy.
All right, Representative Elkins moves that House File 58 be recommended to be referred to the Committee on Health, Finance, and Policy. Representative Elkins, would you describe your bill?
Yes, should I offer I have an amendment, an author's amendment for this one as well. Should we move this one also?
We can do the amendment now if you'd like to do that before your remarks.
Let's do the amendment first then. I'll move the A1 amendment, and this amendment does a couple of things. It deletes Article 3 in the original bill, which was the provision related to prior authorizations. We're going to save that discussion for another day. And with respect to the two remaining articles, 1 and 2, Article 1 is related to prices, and Article 2 is related to formulary stabilization. And we're adding a provision that if for some reason Article 1 is struck down in court, then then Article 2 would go down with it, and the whole bill would be struck down. So it's an inseverability clause.
Okay. Representative Elkins has moved the A1 amendment, which is an author's amendment, getting the bill in the shape that he would like the committee to consider it. Any discussion to the amendment? Seeing no discussion, I'd ask all in favor to say aye.
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 Opposed? The motion prevails and the A1 amendment is adopted. Representative Elkins, if you could explain the bill, and I will ask you to keep your remarks relatively brief. We're running low on time.
Got it. So this one is one of a progression of drug price regulation bills starting back in 2019 with Dr. Mann's PBM regulation bill, Dr. Morrison's drug price transparency 1 bill. This one is a combination of 2 bills that were in last session, a bill that I had that would have required the drug manufacturers to file their prices, one that Hunter Cantrell had on behalf of the Minnesota Medical Association to form basic stabilized drug formularies. This bill is a combination of those 2. So the drug price transparency piece is the first article. The drug formulary stabilization is the second article, and they're inextricably tied together in this bill. So under House 558, both manufacturers and PBMs and plans would be required to file their offerings in advance and then honor them for the duration of the next calendar year. So the development cycle in the development of a health plan and its formulary, and it begins, and I'm going to hold on a second here. Sorry about that. It begins at the beginning of the year. So from a drug point of view, we'll say that the starting point is the manufacturer setting their wholesale acquisition cost, which is the list price. The PBMs and the plans then work with the manufacturers to negotiate discounts and rebates with them, which they then in turn, in the third step, develop into the insurance plans, which have to be filed with the Commerce Department in the May-June timeframe of each year. Once those are approved by the Department of Commerce, we have the open enrollment period in the fall where the patients select their plans. And during the open enrollment, typically the patient, I know that's how I approach open enrollment, is you look to make sure that your doctors are in network and that the drugs that you've been prescribed are on the formulary and a favorable tier that results in them costing as little as possible. And then in January, the plans become effective and patients start beginning to submitting claims. So we've been in this death spiral that seems to be mediating a little bit each year, where we go through this process in year one, and then on January 1st of the following year, as soon as the plans go into effect, the drug manufacturers all raise their prices, knowing that the plans and the PBMs are locked into their formularies, and that it's difficult for them to change the formularies without having a big negative impact on clients taking those drugs.
Representative Elkins, I'm sorry to interrupt. If we're going to get through all the testimony today, I really need you to wrap up in the next minute or two here.
Yeah, got it. So what this bill does basically is it says, drug companies, you know what your prices are going to be next January. Let the plans and the PBMs know early enough in the year so that they can build next year's prices into their formularies, and then freeze those prices for the course of the year so that the plans and the PBMs in terms can freeze their formularies, because nothing is worse for a patient taking an expensive drug is to have the drug that was on the formulary in a favorable tier suddenly not be there anymore, cost more, not be available. So there's a direct correlation here is saying we want the manufacturers to advise us of their price increases in advance, and then having done that, expect the plans and the PBMs to hold to their formula. So we're not, I'll just skip through this one, but basically, the bill requires the drug manufacturers to report their list prices, the wholesale acquisition cost and the average wholesale price, which are the reference prices. People don't actually pay these, but these are the prices that drive everything that occurs in this entire value chain. Both of those are starting points for negotiation. They're established by the manufacturers. Over half the brand name drug purchases by patients are prices that are tied to the WAC through coinsurance payments expressed as a percentage of it. And these reference prices are widely distributed throughout the trade by drug data aggregators like First Data Bank and Wolters Kluwer. So they're not trade secrets. Everyone in the trade knows what these are. In fact, the trade could not operate if these prices were not widely known among the trade.
Okay, and Representative Elkins, we really need to move to.
That's fine. We can. I think that's an adequate discussion, and we can move on to questions and testimony.
I want to make sure we get all the testimony in and give all of our members a chance to weigh in, and we're running low on time here. So we do have a number of people who have signed up to testify. I'm going to ask the public testifiers to limit their comments to 2 minutes. As you just saw, I was even willing to cut off the author of the bill. So I certainly would ask for everyone's cooperation with that. So we can have a full discussion. The first testifier is Dr. Marilyn Paetzo with Minnesota Medical Association. Dr. Paetzo.
Mr. Chair and members, I will dispense with my name and work history. I'm the president of the Minnesota Medical Association, testifying in strong support of House File 58. Articles 2 and 3 of the bill speak to issues that the MMA has been working on with a bipartisan group of legislators for several years. I personally have treated many pediatric patients who have chronic conditions requiring chronic medications for many years: asthma, diabetes, congenital heart disease, cystic fibrosis, etc. It's critical to find and maintain the right treatment to maximize health and quality of life. It can be harmful if the patient's doing well on a medication to have that successful drug no longer covered by the insurance company. Suddenly, parent finds out when they go to the pharmacy to refill the med, no warning. Sometimes changing from one drug to another in the same class can work seamlessly, but for certain conditions like mental health disorders, congenital heart disease, multiple sclerosis, and others, changing meds midstream can put the patient at severe risk of deterioration. These changes are done in the name of saving costs, but for example, if a patient can't get their asthma inhaler in a timely manner, they may end up in the emergency room, they may miss a week of school, the parent may miss a week of work. If a patient cannot get their successful antipsychotic medication that has stabilized their condition, they may end up in the county jail, or they may end up hospitalized for weeks, setting their condition back by months or years. These are real scenarios. The human cost cannot be calculated. The cost to taxpayers will in the end far outweigh the cost of continuing successful prescription medication. Article 2 does two important things. First, it requires insurers and PBMs to use real-time prescription benefit standard developed by the National Council for Prescription Drug Programs. This tool would result in prescribers being informed real time when that drug is covered. This would be so practical and so welcome. Second, Article 2 allows patients who are using a covered drug that is working to maintain that coverage through the remainder of their contract year. The bill doesn't prohibit the PBMs from changing their formularies. They can add new drugs, but it would prohibit forcing the patient to switch drugs once they have started a therapy that was originally covered, waiting until the end of the patient's enrollment year.
And Dr. Pazzo, if you could wrap up your remarks, please.
I will do so. This process has a real effect on burnout in physicians and other prescribers. So in summary, I ask you to support House File 58. Thank you.
Thank you, Dr. Pizzo. The next testifier is Dan Andreessen with the Minnesota Council of Health Plans. Mr. Andreessen.
Thank you, Mr. Chair. You hear me?
I can.
Okay, thank you, Mr. Chair, members of the committee. My name is Dan Andreessen with the Minnesota Council of Health Plans, the trade association for the 7 nonprofit plans here in Minnesota. We know this has been an issue of concern with patient and provider groups in the past sessions, and we understand the need for consistency in maintaining access to medications. Our plans strive to make few changes to the formulary throughout a plan year. For our plans in the fully insured market, these changes are rare, but if they do happen, it's because a drug manufacturer has decided to increase their prices in the middle of the year. We appreciate the approach Representative Elkins is taking with House File 58 and to address the root cause of formulary changes, and that's the inability of drug manufacturers to keep prices steady. We've all seen the news of escalation of drug prices, especially when it comes to insulin and EpiPens and medications to treat arthritis, multiple sclerosis, hepatitis C, and others. The cost of prescription drugs now exceed the cost of inpatient hospitalization, and health plans are trying to manage these costs so enrollees have access to the most cost-effective treatments. House File 58 may not impact this overall escalation in prices, but it will keep prices steady for a 12-month period. With the language in House File 58 to freeze drug prices, our plans will be able to maintain a formulary over this same period. Now, I'll note that I can only speak for our plans in the fully insured market and the 12-month standard that they will need to meet. The state public programs in this bill will be held to a lower, different standard. With the changes being made in the A1 amendment, the council is now neutral on the bill and will continue to be so if this language is maintained as the bill progresses. I'd like to thank Representative Elkins for his leadership and our appreciation for working with us on this legislation. Thank you.
Thank you, Mr. Andreessen. The next testifier is Peter Felstad. Mr. Felstad?
Yes, can you hear me, Chair Stevenson?
I can.
Okay, thank you very much, Chair Stevenson and members of the committee. Good afternoon. My name is Peter Fjelsted. I'm a Senior Director of State Policy for Pharma Trade Association for 33 biopharmaceutical manufacturers that make brand name medicines that save and improve lives for patients every day. Over half of our companies are currently making treatments or vaccines for COVID-19, including 15 clinical trials currently occurring in Minnesota right now. Today, I respectfully oppose House File 58 for the following reasons. First, it imposes a harmful price control, which could discourage research and development for new treatments and cures in Minnesota. Second, it raises serious legal concerns. Third, it fails to consider the real problem of high costs of medicines for patients, which is a health plan benefit design. Lastly, the bill's language may harm Minnesota's economy. But first, I'd just like to mention that the state doesn't even receive the complete record of the required information from last year's price transparency law until October of 2021. That's about 9 months from now. Additionally, a legislative report containing all that information isn't even required to be delivered to the legislature until January of 2022. And that's because that the legislature won't be able to digest all the data. MDH needs to digest it and analyze it and then provide it over the between October and January in order to give a better picture on what the intent and what the options are going forward based on the 2020 law. We believe additional manufacturer language is definitely an instance of getting the cart before the horse. Second, we believe this bill contains a harmful price control. Implementing a price control could harm R&D in the state. We believe that in instances of government price controls on prescription drugs, there can be a delay of over a year from the time a drug is approved until the time that a patient has access. The bill raises legal concerns having to do with federal patent law, the supremacy clause, and the dormant commerce clause. We do appreciate the language that Representative Elkins has included in his bill to provide health plan benefit design transparency. Patients are paying much more out of pocket every single year for their medicines at the counter or those that they receive by mail.
And Mr. Fjellstead, I'm going to have to ask you to wrap up your remarks, please.
Yes, Chair. Just in summary, if any patients have any access or cost problems, we'd just like to direct them to one of the handouts or MAT.org, that's Medical Assistance Tool.org. They can get 950 different patient assistance programs to pay for their drugs if they're unable to. Thank you, Chair Stevenson and committee members for your time today, for all the reasons I've laid out.
Yeah, thank you, Mr. Fjellstead. The next testifier is Alex Sommer of Prime Therapeutics. Mr. Sommer.
Good afternoon, members of the committee. Representative Elkins, just want to call you out and thank you for your opportunity to work with you and I guess your willingness to sit down with us throughout this process. The main thing here that we want to focus on is the inseparability piece here. And I think what you're asking us to do here is to basically take a $15 to $20 million bet on an unproven legal theory. I think that while I appreciate the outside the box thinking, I think that it's very difficult for us to rely on it moving forward, knowing that the cost to taxpayers, or I guess our members who are Minnesota taxpayers, will be so significant. So with that, I really want to turn most of my time to questions from the committee and to Michelle Mack from our trade organization from PCMA.
All right, thank you, Mr. Sommer. Then we have Michelle Mack. Ms. Mack.
Good afternoon, Chairman Stevenson and members of the committee. My name is Michelle Mack, and I'm a director at the Pharmaceutical Care Management Association, PCMA. PCMA represents America's PBMs, which are referred to as pharmacy benefit managers. PCMA appreciates the opportunity to testify on this bill and acknowledges and appreciates Representative Elkins for looking for ways to balance a very complicated system. However, our industry has significant concerns about the bill, specifically Article 2, Section 3, which we refer to as frozen formulary. We believe this will restrict our ability to put downward pressure on pharmaceutical manufacturers to limit the increase of prescription drug costs. While we applaud Representative Elkins for including language that would prohibit pharmaceutical manufacturers from increasing the wholesale acquisition cost of a drug on a formulary, this does show that there is an acknowledgement there is a cost association to the frozen formulary portion of the bill. A new report released last week by Milliman, which we submitted, shows that this type of form of policy would cost Minnesota healthcare payers $75 million over 5 years. Unfortunately, the state does not have the authority to limit what pharmaceutical manufacturers charge. PBMs help provide their members access to safe, effective, and affordable medications, but pricing in the drug market is volatile, and there are very few tools to incent drug manufacturers to reduce prices. Formulary placement and financial incentives to use low-cost generics and brand alternatives are among those tools. This bill threatens those cost savings mechanisms. Currently, there are appeals processes which health plans and PBMs have in place for patients to access non-formulary drugs. And the health plans or PBMs work with the patient to provide access to those non-formulary drugs where medically necessary and or likely to create the best clinical outcome. And we believe our appeals processes are fair and responsive. Finally, I'd like to thank Representative Elkins for his amendment removing additional changes to prior authorization, which was just passed in 2020. And also, in addition, in 2019, there was as he indicated, there was the PBM licensure and reporting that was enacted, and we're awaiting proposed rules on that. And we caution against implementing another new law without allowing what was enacted to be fully implemented. In closing, PCMA believes that House File 58 will raise prescription drug costs as it removes important tools that PBMs use to deliver high-quality services. Thank you for your time and consideration, and I'd be happy to answer any questions.
Thank you, Ms. Mack. Our next testifier is Brett Michelin. Mr. Michelin.
Good afternoon, Mr. Chairman and members. Brett Michelin with the Association for Accessible Medicines. AAM represents the generic and biosimilar manufacturers. And I'd also like to thank Mr. Representative Elkins for the time he spent with us. I think it's been very beneficial. I'd like to focus on really two provisions in the bill. The first being the requirement to report all WACs, wholesale acquisition costs. Much of what's been discussed by the supporters and actually now some of the opposition doesn't really apply on the generic side of the pharmaceutical market. The way our manufacturers work is they sell literally 90% of all generic drugs to 3 purchasers. After that, the generic manufacturer is out of the pricing picture. So that means that we would be required to report a WAC price that then is changed by the wholesaler, the insurer, the PBM, the pharmacy, and everyone else in the supply chain. So as some of the earlier bills where you were talking about comparing prices and allowing somebody to shop, seeing a WAC price, especially on the generic side, is not going to provide beneficial information. In fact, it could lead to confusion at the pharmacy counter if they see a price put out on that's negotiated between the manufacturer and the wholesaler. Again, 3 purchasers buy 90% of all generic drugs. After that, we're out of the pricing game. The second provision that I'd like to bring up is actually, we think, antithetical to the author's goal of reducing drug costs. And that, as mentioned earlier, is where it prohibits a manufacturer from changing a WAC price. Generic drugs are a commodity. That means we go up and down in price consistently. By locking in a WAC price, that would prohibit those deductions or reductions. In fact, generic drugs are really the only depreciating value in healthcare. We are what is keeping many of the costs down for purchasers. Think of it this way: if one company is selling the same drug, other generic manufacturers come in selling the same drug, we are now locked into a price, or the company A will be locked into a price. Other companies will come in with lower costs. That prohibits the first company from reducing their costs to compete in the market.
All right, Mr. Michelin, if I could ask you to please wrap up your testimony.
2 more sentences and I'll be done. Thank you very much. Appreciate it. Plans set their formularies at different times of the year. So if a manufacturer sets a WAC price for one plan, it's not allowed to change its WAC price for other plans as they're developing their formularies. And this could extend that increased cost throughout the life cycle of that one manufacturer. And happy to take questions, and thank you for your time.
Thank you, Mr. Michelin. Our last testifier is Bentley Graves of the Chamber of Commerce. Mr. Graves.
Thank you, Mr. Chair. The blessing and the curse of being the final testifier. There is much said here, and I don't want to cover all that ground again, but I'll keep my comments brief. I do want to thank Representative Elkins for removing the prior auth piece. As was noted, there was a lot of work done on that last session, but I appreciate his engagement. And just to note too that this issue of frozen formula is one that we have been engaged in for a number of years, as Dr. Pezzo mentioned. And we've struggled with this tension as well between costs and access. This is, as was mentioned, kind of an outside of the box approach and a creative approach by Representative Elkins, and we applaud him for that. We are nevertheless kind of caught in this tension between looking at this as a creative approach to solve the problem, and as a business organization wrestling with the idea of the state coming in and in this case freezing prices. But it is a significant issue, as you've heard from all the testimony. We are committed to the continued conversation and look forward to hopefully finding some resolution to it that balances that access and cost concern. So thank you, Mr. Chair. Thank you, Representative Elkins. Thank you, committee members, for the time today.
All right, no further testifiers. We'll move to member discussion. Representative Farr.
Thank you, Mr. Chair. Thank you, Representative Elkins, for your bill. So I apologize. I was hitting the clap my hands button during the amendment versus the raise my hand button. But my question there is, with the amendment and being we're tying price controls to the formulary controls, if this shouldn't go through judiciary as well, because I see some potential issues there. And so I don't know if it's my.
Thank you, Representative. Oh, hold on, Representative Elkins. Representative Farr, thank you for the question, and I apologize. I just thought you were really enthusiastic about that. But we did discuss these files with the chair of the Judiciary Committee, and it at this time doesn't need to go there. So the referral after this committee will be to the Health Committee. Representative Farr, did you have anything else you wanted to comment on?
No, that's it. Thank you.
And again, I do apologize for missing you. I did see you clapping your hands. I just misinterpreted that. Representative Haley. All right, we'll move on to Representative O'Driscoll.
Thank you, Mr. Chair and members. I've got some concerns about the nature of this bill. It seems like we had three pretty controversial bills today, or bills that people had a lot of input on. They're all about transparency, and we're kind of running out of time here, and testifiers were being sort of rushed along the way, which I, as a chair, know what that's like. And Mr. Chair, I'm hoping that with this particular bill, since it's brought up a lot of extra conversation, and even the bill author was wanting to tell us more about the nature and depth and scope of this bill, then we might lay it over for further consideration. Certainly in this world of COVID and where we are at, it's very difficult for people to be able to get in, get connected, get into the committee, to be heard, to be giving their thoughts. So, and out of deference to the theme of the day, transparency, I'm hoping that we can lay this bill over, and then we can also take it up next week when we have more time to be able to vet this. So from one former chair to a current chair, that's my hope and wish for this committee and these particular bills. Thank you, Mr. Chair.
Thank you, Representative O'Driscoll. Representative Haley, it appears you're back. Representative Haley.
I have many questions, and I would appreciate if we can continue this discussion on further committee, but wanted to ask the bill author why the difference in the public programs having every quarter of requirement and the private sector being annual.
Representative Elkins.
Yes, thank you, Mr. Chair. Representative Haley, I think that Chad Hope from the Department of Human Services is on the call specifically to be able to, be able to field that question.
Mr. Hope.
Good afternoon. Thank you, Mr. Chair, Representative. My name is Chad Hope, Deputy Director for Purchasing and Service Delivery at DHS. The reason for that change is there are two reasons that public programs are different. The first is our members don't have a defined benefit year. They're continuously eligible until they're either off public programs or then they just keep renewing their eligibility. And the second is drug prices are impacted by the federal Medicaid drug rebate, which is controlled by CMS and the manufacturers. Those prices can change quarterly regardless of what the list prices are. So while we don't typically have changes every quarter, the rebate can change quarterly and it could lead to significant changes. Therefore, we need the flexibility to be able to respond to dramatic shifts in that federal rebate as frequently as quarterly.
Representative Haley.
Thank you, Mr. Chair.
Representative Tice.
Thank you, Mr. Chair. And I guess I would ask too, I've been doing some homework here, trying to figure this out as somebody who has a chronic illness, diabetes. I'm trying to figure out how this is going to affect what it's going to cost me for my prescriptions. I'm not really sure that it's going to make it any cheaper. It might be more transparent, but I also know that there are times when I'm on, my doctor and I discuss a certain medication, I'm on it, I like it, and then my PBM says, oh, no, we're going to just switch you without any consultation at all. And I'm leery about messing with what seems to be working right now. So it would be nice to be able to extend this dialogue, and I'd like to hear more from actually Representative Elkins. He's got a lot of information, and I really feel like we're going to be making a vote without having all the information before us. So I would echo what Representative O'Driscoll has said, and could we please lay this over so that we can get a better picture of what exactly this is, because right now, I'm not even really sure what it means. Thank you.
Representative Tice, did you have a specific question you wanted to ask Representative Elkins? We still have ample time left in our committee for discussion.
Actually, we've got caucus at 4:30, so we don't.
Well, there's still 5 minutes left. I'm asking, did you have a question you wanted to ask Representative Elkins?
It's not just going to be one question. It's going to be a myriad of questions. But actually, looking through some of the slides too, I'd like to know what more information he has to give to us so that I'm able to make a better decision.
All right. Well, Representative Tice, I'm sure Representative Elkins would be happy to send you a copy of this slide deck, and you can review it. Of course, the bill has other committee stops to make after this one, and it will be heard on the floor as well. I see no further members seeking recognition. Representative Elkins, do you have any closing comments?
Just I would respond to one thing. I have not referred to this as a frozen formulary bill. I would refer to it as formulary stabilization, because it doesn't freeze the formulary. All it does is it says if you're on a drug, you're grandfathered in even if the formulary changes. So that, I think that's an important clarification. So, and if members want to discuss this with me before the next committee stop in healthcare, I'm happy to do that.
Thank you, Representative Elkins. Would you like to renew your motion?
Yes, Mr. Chair, I would like to renew my motion that we refer this move this bill along to the Health, Finance, and Policy Committee as amended.
All right, Representative Elkins renews his motion to recommend that House File 58 as amended be referred to the Committee on Health, Finance, and Policy, and Mr. Brown will take the roll.
Chair Stevenson.
Aye.
Vice Chair Katiza-Wattoon.
Aye.
Representative O'Driscoll.
No.
Representative Barr.
No.
Representative Carlson.
Yes.
Representative Davnie.
Aye.
Representative Elkins.
Aye.
Representative Haley.
No.
Representative Cagle.
Aye.
Representative Lee.
Aye.
Representative Lilly. Representative Lislegard.
Aye.
Representative Lucero.
No.
Representative Olson.
Aye.
Representative Farr.
No.
Representative Rasmussen.
No.
Representative Richardson.
Aye.
Representative Tice.
No.
And I'll ask again for Representative Lilly.
Thank you. Sorry. Aye.
Thank you.
There being 11 ayes and 7 nays, the motion prevails, and House File 58 is recommended to be referred to the Committee on Health, Finance, and Policy. This concludes our agenda for today's hearing, and so until next Tuesday, the committee is adjourned.